In this case, we will be discussing TMJ osteoarthritis. Chief complaint. A 20-year-old female presents with TMJ pain that has progressed over the past 6 months. Conservative treatment with both systemic and topical NSAIDs only helped a little in the past. She was given a left TMJ steroid injection 1 year ago, which gave her relief for 7 to 8 months. She has begun to notice pain in the right TMJ. She was not able to treat the right TMJ due to financial constraints. Both TMJs are painful when eating hard foods, talking, or opening wide. She states she has fullness in both ears, but is not seeing an ENT. She feels the pain is from clenching and grinding her teeth. She has not been using her night guard that was made for her because she feels it increases her clenching and jaw soreness in the morning. She states she is under increased stress lately and has been treated by a psychiatrist. So for the history of present illness, this pain began about 6 months ago. The causation she believes is clenching, grinding. The location is in the right and left TMJ. The type of pain is dull ache and sharp pain. It's on and off all day long. The sharp pain lasts a couple of minutes, but the dull achy pain is constant. The severity is moderate to severe. Ice makes it better, and opening wide hard foods and talking a lot makes the pain worse. She does have a headache history. Her headache started in childhood. The causation is jaw pain, neck pain, or vision. She has a vision condition that's being treated due to ocular muscles not allowing convergence of the eyes. The location of her headaches are bilateral temporal area, occipital, and around the eyes. The quality is achy, stabbing, and sometimes with light and sound sensitivity and nausea. Frequency, up to 5 days a week. Attack duration, so these headaches are hours and the severity is mild to severe depending on the type of headache. Aleve makes them better, and when her jaw is aggravated, her headaches are actually worse. For her medical history, she has been diagnosed with obsessive compulsive disorder and anxiety. She's currently taking Buspar and Lexapro. She is not willing to switch her SSRI medication to a TCA or SNRI because she feels her OCD and anxiety are controlled with her medication. Her sleep history, she does not sleep well and has nightmares. For social history, she does admit to grinding and clenching her teeth. She currently is more stressed. She lost her insurance, her dad lost his job, and she just started school. She is currently being treated by a psychiatrist for her stress, anxiety, and OCD. During the extraoral exam, the palpation of craniofacial muscles showed moderate to severe pain on the right masseter that referred to the TMJ. She also had severe pain on temporalis tendon and also on the right, and she had moderate on the left temporalis tendon, and the right lateral pterygoid showed mild pain. For palpation of the temporomandibular joint, the right lateral condyle showed severe pain. The left lateral condyle had moderate pain. Her max pain-free opening was 41 without pain and 49 with pain. Right-left lateral max was 10 plus, which is normal. And when listening to the joint with the stethoscope, we did hear crepitation in both the right and left TMJ. The intraoral exam showed normal gingival, alveolar, and mucosal tissues. She did have mild canine dentition, similar to what's shown in this picture where the canines are slightly worn down. Normal posterior contact with mylar, no contact on 8 and 9, which is normal. In this case, we took a panoramic x-ray. It's a little bit difficult to see the condyles in this picture. From what we can deduce in this picture, everything looks normal. However, it's slightly unclear. For the assessment, the main diagnosis was TMJ osteoarthritis, followed by myofascial pain. She also presented with 2 different types of headaches, both tension type headache and migraine without aura. Tendinitis in the temporalis tendon and tinnitus. For the treatment plan, I recommended myofascial protocol including avoidance therapy, end position stretch, thermal therapy. The patient's aware of possible progression of TMD symptoms. I recommended continuing to wear the night guard to protect her teeth from further wear. Recommended steroid injection on the right TMJ. The patient agreed, the consent was signed, and I injected 0.5 cc's of Kenalog 40 and 1.5 cc of 2% lidocaine without epinephrine into the right superior joint space without complication. I also recommended a trigger point injection into the right masseter. Patient agreed, consent signed. I injected 1 cc of 1% lidocaine without epinephrine into the right masseter without complication. Patient is aware of possible future TMJ cone beam CT and TMJ hyaluronic injection, possibly TMJ steroid injection, or possible trigger point injections or future arthrocentesis if all conservative treatment fails. Possible future referral to ENT if tinnitus does not resolve with the TMD symptoms resolving. And possible future referral to neurologist if headaches do not resolve when the TMD symptoms subside. For the next visit, we will reevaluate her symptoms in 1 week. Visit number 2. Patient returns for a follow-up visit. It has been 1 week since the TMJ steroid injection and trigger point injection in the right side. Yesterday, she began to feel a little bit better. The sharp pain is better, but she still has soreness and achiness. She has sharp pain only if she opens too wide. We discussed opening wide should be avoided. Went over avoidance protocol again. Overall, she's doing 50% better on the right side. But now, the right side feels better. The pain on the left side is more apparent. So during the exam, palpation of craniofacial muscles showed that the left masseter has a moderate intensity of pain and refers to the TMJ. She also had some other findings of pain on the muscles of mastication. Palpation of the TMJs, the left lateral condyle was actually severe pain, sharp pain. The right lateral condyle had actually decreased to actually a moderate pain, and it was more of a tender instead of sharp pain. For the assessment, we have the same diagnosis, but the pain is more on the left side today. For the treatment plan, I recommended left steroid joint injection and left masseter trigger point injection. I injected 0.5 cc's of Kenalog 40 and 1.5 cc's of 2% lidocaine without epinephrine into the left superior joint space without complication. I then injected 0.5 cc's of 1% lidocaine without epinephrine into the left masseter without complication. Patient did well, and we'll follow up in 1 week. Visit number 3. Patient returned after 1 week. She claims she feels great. Her pain is 80% better. She is very happy with the results. Her headaches and her tinnitus are better as well. So we'll follow up with this patient in 1 month. Well, what is osteoarthritis? Osteoarthritis is a disease of bone, cartilage, and of supporting tissues as a result of both mechanical and biologic events. And how is it diagnosed? Well, it's diagnosed by radiographic examination of the joint, actually with cone beam CT or panoramic, although cone beam CT is more accurate. It's characterized by degeneration of the joint cartilage with osseous erosion and sclerosis and sometimes osteophyte formation at the joint margins. We can also diagnose osteoarthritis by listening to the TMJs with a stethoscope detecting clinical crepitus, which is a grating noise. Pain to palpation is also important with osteoarthritis. That's performed by applying 1 kilogram of pressure to the lateral and dorsal capsule of the TMJ. I have a nice picture here showing bony changes of the condyle. In picture A, we see a normal condyle. In B, we see flattening. C, some sclerotic changes. In D, we have an osteophyte formation. And in E, evidence of erosion. What are the treatment options for osteoarthritis? Well, we always start with avoidance protocol. We want to make sure that the things that are aggravating the joint are actually avoided, such as hard foods, crunchy foods, opening wide, habits, all of those things that were discussed in the PowerPoint on capsulitis. NSAIDs, topical or systemic, are also helpful in osteoarthritis. And of course, intra-articular injections of corticosteroids or hyaluronic acid in more severe cases. In this case, the patient had tried conservative treatment in the past with topical NSAID cream and systemic NSAIDs, which really only helped her a little bit. What helped her the most was the steroid injection. Well, what does the research say? There was a long-term study done over 8 years by Weinberg and Company of the effects of intra-articular injections of glucosteroids into the TMJs on subjective and clinical dysfunctions patients with TMJ osteoarthritis. The subjective symptoms as well as the clinical signs were significantly reduced at follow-up examination. And interestingly, erosions of the bony articular margins of the TMJ that could be observed radiographically before treatment were found to be remineralized at follow-up and associated with bone remodeling of the joint. So their results indicate that long-term prognosis of intra-articular steroid injections for TMJ arthritis is good and that there are no radiographically demonstrable side effects of the treatment. And as I mentioned in this case, the patient had tried other treatments that were more conservative, and for her, this seemed to be the treatment that worked best for her.